Good evening, everyone, and welcome to GADA's webinar for Aortic Dissection Awareness Week, understanding the signs, risk, care, and management practices for those with genetic aortic disorders. So I'm pleased to introduce our four panelists today. But before we start, I'm just going to go over our disclaimer. So the information, in particular, the medical and scientific information contained in this virtual event is provided with the understanding that this program is provided by a voluntary health organization and is not engaged in rendering medical advice or recommendations on diagnosis, treatment of any aortic or genetic aortic disorder. The contents of this webinar, such as presentations, discussions, text, graphic, images, and other materials, are for educational and informational purposes only and as a benefit and service in the furtherance of GADA Canada. Genetic aortic disorders are complex and multisystemic that can only be properly diagnosed and managed by skilled and trained health professionals. The manifestations and severity of these disorders vary greatly among individuals, even within the same family, and require personalized medical management. None of the medications, courses of treatment, lifestyle, and activity recommendations discussed in this virtual event or the GADA Canada website should replace necessary consultations with a qualified healthcare professional. GADA Canada, or the Genetic Aortic Disorders Association of Canada, is a registered patient advocacy organization promoting research-based awareness, education, and support to patients with genetic aortic disorders. We are dedicated to saving lives and enabling a promising future for individuals living with genetic aortic disorders, including Marfan syndrome. Co-founded by GANA, the Montalcino Aortic Consortium is an international research collaborative of multidisciplinary clinicians collecting patient data to generate gene and variant-specific risk models for personalized medicine to improve the outcomes of individuals with genetic aortic disease. Our first presenter is Dr. Gnalini Sathananthan. I'm sorry, I think I just mispronounced that. She's a cardiologist based in St. Paul's Hospital in Vancouver, Canada, an echocardiographer, adult congenital heart disease specialist, and the medical lead of the Provincial Heritable Aortopathy Program in British Columbia. She's a member of the Montalcino Aortic Consortium and has a strong interest in increasing awareness and improving outcomes for patients with heritable aortopathy. Our second speaker is Dr. Siddharth Prakash. He has a PhD in molecular and human genetics from Baylor College of Medicine, where he also completed his residency in internal medicine and fellowship in cardiovascular disease. He's a board certified in cardiology, echocardiography, and adult congenital heart disease. Since 2011, Dr. Prakash has worked as a cardiologist in the multidisciplinary aortic and valvular disease clinic at the McGovern Medical School as part of the University of Texas Health Sciences Center at Houston, where he specializes in medical therapy, imaging, and surveillance of patients with heritable aortic and vascular diseases. He's a professor of internal medicine, is the co-director of the Turner Syndrome Adult Comprehensive Care Center, a multidisciplinary clinic that sees Turner syndrome patients from across the Southwest region of the U.S. He leads a national Turner Syndrome research registry, and is the chair of the scientific advisory board of the Turner Syndrome Society of the U.S. He also co-chairs the Collaborative Clinical Science Working Group of the GenTech Alliance and is an investigator with the Montalcino Aortic Consortium. Dr. Prakash's translational research focuses on the contribution of rare genetic variants to bicuspid aortic valve, the most common in congenital heart defect. Dr. Prakash uses innovative strategy to identify new candidate genes for bicuspid aortic valve based in part on the hypothesis that reduced dosage of genes on the X chromosome is responsible for sex differences in the prevalence of bicuspid aortic valve and other congenital heart diseases. His team demonstrated that specific rare variants predict complications in patients with bicuspid aortic valve. Dr. Prakash has received funding from the National Science Foundation, the American Heart Association, the NIH, and the John Ritter Foundation for Aortic Health, which funded the first clinical trial of exercise in aortic dissection survivors led by Dr. Prakash. Thirdly, we have Dr. Julie Richer, a medical geneticist at the Children's Hospital of Eastern Ontario and an associate professor at the University of Ottawa. Her clinical practice primarily consists of the care of patients with underlying connective tissue disorders such as familial thoracic aneurysms and cardiogenetic disorders. In 2012, she founded a heritable connective tissue and arteriopathy clinic, which bridges care for the adult and pediatric worlds. Dr. Rishi spearheaded and chairs the virtual Trans-Canada Aortopathy Round, an educational session for geneticists, genetic counselors, and cardiologists and other medical professionals. These rounds take place at least 6 times per year since the fall of 2021. In May 2022, Dr. Richer became the lead cardiogenetics expert group for the Provincial Genetic Program in Ontario. She is a member of the International ClinGen HTAD Gene Curation Expert Panel and of the Montalcino Aortic Consortium. She has previously served on the Canadian Medical Association Ethics Committee and chaired the Ethics, Education and Public Policy Committee of the Canadian College of Medical Genetics, and served as the Vice Chair of the Specialty Committee for Medical Genetics at the Royal College of Physicians and Surgeons of Canada. Dr. Richer completed medical school at Université de Montréal in medical genetics at the University of Manitoba and a fellowship in medical ethics at Harvard University. Last but not least is Gretchen MacCarrick, who's an assistant professor in the McKusick-Nathans Department of Genetic Medicine at Johns Hopkins University, where she's the co-director of the Cardiovascular Connective Tissue Disease Clinic. She has expertise with mental health and other support topics for the aortic disease population through her involvement as an advisory capacity for the Marfan and Loeys-Dietz syndrome foundations. Okay, without any further ado, I will hand this over.
Is it okay if I share my screen?
Yep, go ahead.
Does that look okay? Okay. So thank you for the introduction. My name's Gnalini Sathananthan, and as already mentioned, I'm a cardiologist at St. Paul's Hospital in Vancouver, Canada. My only disclosure is that I am not a cardiac surgeon, so I do not operate on patients. So I will briefly mention some surgical information, but just to be noteworthy that I'm not a surgeon. The topic that I've been asked to talk about is understanding aortic dissection, and I've intentionally titled it Knowledge That Empowers. I know there are a number of patients and possibly family members of patients here tonight, and I know that you're all here to be informed and to increase your knowledge on a topic that's obviously quite relevant to you or someone close to you. And I think it's just important that knowledge can obviously at times be quite daunting, anxiety-provoking, and it can instill fear as well. But on the flip side of that, it can be very empowering, and it can really arm you with the information that you need to advocate for yourself or a family member. And that is the aim of tonight's webinar. So this is the reason we're here this week. It is Aortic Dissection Awareness Week. And why is that important? Well, aortic dissections are a time-critical, life-threatening disease, and it has a high fatality rate. And so we know that in a dissection that involves the first part of the aorta, that mortality or death is 1 to 2% per hour, and the risk of death, if untreated, is 50%, if not attended to within 24 hours. That's why it's important, and that's why we're here to discuss this a little bit more. So the objectives of the talk today is we're going to go through the anatomy of the aorta. We're going to understand what an aortic dissection is, understand who is at risk, the signs and symptoms to look out for, learn what to communicate to your healthcare provider, and pre- and post-surgery management. So this is the anatomy of the aorta. You can see on the little diagram on the left of the person that the aorta is a big structure, and it sits in the chest, but it extends all the way down into your abdomen or your tummy as well. And it goes to the top of your legs. And so on the bigger diagram here of your aorta, you can see, I don't think you can probably see my cursor, but you can see this area, the bulb right at the start of the aorta, which is known as the aortic root. Another name for it you might hear is the sinus of Valsalva. That's more of a term used when we're measuring certain measurements in that area. And it is attached to the heart. So the heart is just below that aortic root, and that's that kind of off-shadowed structure that's sitting below that. And then as you move upward in the aorta, you go to the ascending aorta, which is the first part. Then you go to the arch, which is the little bridge piece at the top, which has those branches which connect up to your head. And then you can keep going down the descending aorta, and it sits right up to, well, the descending aorta, the thoracic descending aorta goes right until the diaphragm. So once it's past the diaphragm, it's then termed the abdominal aorta. So the abdominal aorta keeps heading down, and as I said, it branches here at the bottom and each of the branches go towards either leg. And you can see that in the abdomen, there are also multiple branches, and the abdominal aorta is providing blood flow to various structures in the abdomen, such as your kidneys, your bowel, etc. So you can see on the left-hand side here, there's lots of numbers on the aorta, and that is not something you need to remember or know, but it's a way that in terms of for medical people to gauge where there has been an acute event, and it's definitely important for surgeons. So it might be mentioned on CT reports, it might be mentioned surgically, but there's different, there's classification for basically every segment of that aorta because it is a large structure. So we're going to go over to the right image, and this is going to be important because this is going to be how we understand what an aortic dissection actually is. But you can see here the dark red piece, that's the lumen, or the inside of the aorta. So the aorta is like a pipe, and so inside the aorta, that's what that dark piece is. I'm going to call it the lumen. And then as you head out towards the outside of the aorta, there's a name for each layer of vascular tissue. So there's the intima, which is the innermost layer, the media, and then the outermost layer is the adventitia. So an acute aortic syndrome refers to a life-threatening condition, which really breaches the integrity of the aortic valve and requires immediate attention. So technically, there's 3 different conditions regards to the aorta, which can be considered acute: an aortic dissection, an intramural hematoma, and a penetrating atherosclerotic ulcer. So an acute aortic dissection refers to when there is a tear in the aortic intima, so that inside layer, and it leads to blood seeping into the aortic media, that middle layer. And what it does is it pushes that dissection flap, or that outside layer, into the middle of the aorta. So you can see on that diagram on the far right, I hope it's on the right on your screen, and you can see that the flap is pushed to the middle. And so what it ends up creating is something called a true lumen, which is the lumen, or the path that blood usually is flowing through, versus the false lumen, which is what this flap has created. So blood will, because there's a tear, blood is going to go into that false lumen as well. So you may hear medical personnel refer to certain areas as a true lumen and a false lumen. So an aortic dissection technically has different temporal definitions. So you can call it hyperacute if it's within 24 hours of presentation, acute if it's in 2 to 7 days of presentation, subacute 8 to 30 days, and chronic if it's over 30 days. I would say the large majority, especially for a dissection involving the first part of the aorta, would be hyperacute, and generally they're going to be either hyperacute or acute if it involves the other end of the aorta, which I'm going to talk about. Subacute and chronic are less common, but they can happen. So I've already kind of alluded to it. There's different classifications on the type of dissection, and that's important because it influences how they are treated. There's different classifications. You can see at the top, there's the DeBakey classification, which is the type 1, 2, 3A, and 3B. And then there's the Stanford, which is type A and type B. I'm going to go for the simpler one, Stanford. So type A basically involves the ascending aorta. So involves that first part of that aorta. And it doesn't matter if it only involves that aorta or if it involves that ascending and descending aorta. If there is any involvement in the ascending aorta, it's a type A. Versus a type B, which involves the descending aorta, and it can extend more further down, and it can go into the abdominal aorta. So we're going to simply go by type A and type B. So for type A dissections, there's a very high mortality rate or a death rate if it is not treated surgically. So the management for these are urgent surgery, and that would apply to basically nearly all cases. Type B dissections, that is more variable in terms of management, and it depends on whether there is complications related to that dissection or not. And so a complicated acute type B dissection requires intervention immediately, and we can talk about what those would look like later. But complicated means if there's an associated rupture, so it actually ruptures, causes blood to leak out. Malperfusion, meaning that certain areas, and we talked about that false lumen, so certain areas, let's say your kidneys or your bowels, etc., are not getting perfused by the true lumen, where the blood should be going through, and there's not enough blood going to that organ. So malperfusion is a reason which might define it as complicated. Refractory pain, if the patient is having ongoing pain with this dissection. Uncontrolled hypertension, so uncontrolled high blood pressures, which are not controlled by medications, or rapid aortic expansion, which refers to the aorta getting bigger over time. And I should say over time, because if you were admitted with this, you would remain in hospital for several days having serial scans to see how it is progressing. So in that case, if it was a complicated type B, you would require intervention. If it was uncomplicated, didn't have any of those situations, then the strategy is medical therapy. And it has been shown by several studies that medical therapy, meaning really aggressive blood pressure and heart rate control, so you will probably have medications given through drips to try to bring the blood pressure and the heart rate down, that actually has less complications than if you aggressively went and did a procedure to fix it, if it is an uncomplicated type B dissection. I just will quickly touch on the other two types, intramural hematoma. It's basically similar concept about a leak into the aortic media, so that middle layer, but it's more that it's gradual, it forms a clot, and instead of forming a dissection flap, it actually it forms a clot in the outer layer and pushes the wall of the aorta outward. And so in this situation, you do not get a true and a false lumen, you get basically an abnormal hematoma around the aorta. Penetrating atherosclerotic ulcers is more in more elderly patients with high cholesterol. You'll form cholesterol plaques in the wall of the aorta that compromises the integrity of the wall and basically leads to a tear or an outpouching. And similar concept to an intramural hematoma. There's no dissection flap, but it's an outpouching around the outside of the aorta. So who can have an aortic dissection? So anyone with a heritable aortopathy or connective tissue disorders, such as the more common ones listed there, Marfan syndrome, Louis-Dietz, vascular Ehlers-Danlos, and anyone with a family history of aortic aneurysm or dissection is theoretically at risk. And that might be because they're not diagnosed with a condition yet, or it could be a gene-negative condition. Other conditions associated with aortic dissections: bicuspid aortic valve, Turner syndrome, chronic illicit drug use, such as with cocaine or amphetamine, uncontrolled severe hypertension, high blood pressure, high cholesterol, and that is usually in the context of this similar, as what I've talked about, the atherosclerotic plaque building up, causing tears, etc. And older age. As you age, the integrity of your aorta does weaken, and that can just be a consequence of chronic blood pressure issues, cholesterol plaque, and age itself. So the signs and symptoms to watch out for. So, the textbook description is this abrupt, severe chest, abdominal, or back pain. It's quite sudden, and they often describe it as tearing or ripping. But the reality is we know that there's lots of different presentations in the real world. Other things to make you think that this might be what is happening is fainting or losing consciousness, stroke symptoms, weakness or slurred speech, and that's because, as I showed you before, the aorta is connected to vessels that run up to the head and neck. If the dissection flap migrates towards those vessels, it can compromise blood flow to the brain. Heart attack symptoms, similar concept. If it extends into the coronary arteries at the bottom when it connects to the heart, it can cause symptoms that mimic a heart attack. And then other more rarer symptoms, but could be shortness of breath, difficulty swallowing, swelling of arms and neck or face. The key to an accurate diagnosis is a CT scan of the aorta. This is the gold standard, and the reason this has been chosen as the gold standard is because this is available and easily accessible in generally any emergency department, and it's not something that's specific to a tertiary center. And so an aortic dissection can be diagnosed on an echocardiogram or an ultrasound. More challenging depending on how the echocardiogram is done, and it can also be diagnosed on an MRI, and that might be an option if the patient is unable to have a CT. But MRIs are not as easily accessible in every center, and definitely a longer scan time as well. And so the CT is a much shorter scan time and more readily available at whichever emergency department you go to. There's no real blood test that is specifically good for checking for aortic dissection, but you may find in some emergency departments they'll check a D-dimer. And I think the D-dimer, it is a good test for exclusion, but it's for patients who are at low risk of aortic dissection. So it probably isn't the greatest test to test in someone with a heritable aortopathy or family history, etc. But it is something that you might hear if you ended up in an emergency department. So if you were having chest pain or a symptom at home that made you concerned about an aortic dissection, your first port of call would probably be emergency services. And I think the importance is to be, if you can, at that point, communicate. I think the salient points need to be communicated. And these are some things that you could say that might perk their interest and the urgency for your case. So I think I might be having an aortic dissection. I have sudden onset, very severe chest pain. And this is nothing like my usual chest pain. I've never had pain like this before. If you have a syndrome, I would name it. And I put in here Louis-Dietz because it's a little bit less commonly known. I have Louis-Dietz syndrome. It's a rare genetic condition that weakens the aorta, and I am at risk of aortic dissection. I have family members who have had an aortic dissection. I need a CT of my aorta. So this is what you would probably say if you were ringing emergency services or you turned up to an emergency department. But I know in the real world, that's not always possible, that you can, you can rehearse the lines and say it as you had planned to, and you might not be feeling well at the time. And so there needs to be other options on how to communicate this. Some of you probably have already seen this. This is from the Marfan Foundation, and they have an emergency alert card. It's specific. It has a lot of details about Marfan syndrome, but it does mention in here that you might have a similar condition to that. And I think having something like this is a great idea because it allows the card to do the communication for you and say some of the words and some of the medical terms that you may not be able to communicate at the time. Being prepared is the key piece. So there's various things that are available. A medical alert bracelet, having that is a good option. Obviously, very limited with information that can be placed on that, but it's a good starting point. And now the iPhones have medical information that can be put on your lock screen that paramedics can easily access. And on the marfan.org website, there is more information about an emergency preparedness kit, which involves a lot of information about your condition, prior surgeries. It's much more detailed, and you can have one of those readily available, you know, at the front of your house or at work if something were to happen. Other options to put information on a USB key and keep it on your keychain. And I think the other piece is to really inform family and close friends about your condition so that when you do have symptoms that might be concerning, they can also advocate for you as well when you can't. So how to mitigate aortic dissection risk? So good blood pressure control. So when you are measuring, sorry, I got cut off on the end there, but when you're measuring blood pressure on your arm, you're actually measuring the central pressure or the pressure within the aorta. It's very reflective of it. And so keeping good blood pressure control makes sure that your pressure within the aorta is under control. And we know that higher blood pressures put pressure on the aorta can cause aortic dilatation, aorta to get bigger, and high blood pressures can cause tears and dissections. And so I would generally recommend all of my patients in my heritable aortopathy clinic to keep a regular eye on your blood pressure. And, you know, if you have a dilated aorta, or are waiting surgery, etc., you know, the numbers that you may be provided in terms of parameters to follow would be a little bit more stricter than if you had a normal sized aorta. So the numbers will vary. I put on my slide here a blood pressure of less than 120. This was taken from some surgical information that's provided. So those are the numbers that they would provide if you had a big aorta and you were awaiting surgery. So aiming for a blood pressure of less than 120 can be helpful. And so having a blood pressure machine at home, checking it, you know, to begin with once a week and then going to less frequently if it's well controlled, that can be helpful. The other piece is safe exercising, and I've intentionally left that point very scarce because one of the other speakers is going to speak in more detail about it. But again, it comes about by the same principle that the safe exercising is such that there isn't abrupt rises in your blood pressure when you're exercising. So that can be quite useful, and I think one of the other speakers will talk about that more. And working closely with your healthcare provider. So doing the annual or 6 monthly checkups, getting the regular scans, making sure there isn't significant changes in your aorta or any other concerns that might increase your risk. As I said, my slide on surgery is brief, but in terms of surgery, if you had a type A dissection, so involving the first part of the aorta, you would need a median sternotomy. So you would have open heart surgery, and there's various types of surgeries. They might choose to replace your valve. So that's what mechanical CVG is, composite valve graft. They might give you a mechanical valve, they might give you a tissue valve, or in that first instance, they might, if your valve is working okay, they might actually do a valve sparing ascending aorta replacement where they can preserve that valve as the native valve. And then in terms of descending aorta repair, so if they were repairing the descending aorta, you can have open repairs, but there are centers that will also do endovascular repairs or TIVAs. And so they usually will go through the leg and they will insert a stent into that area that is big or getting bigger or dissected and closing off basically that false lumen. So pre-surgical care, you know, the key pieces are to move. Do not stay sedentary. And that can be as simple as just walking about. I'm going to go through these a little bit quicker because I realize my time's coming up. So just being quite active, moving your body, even as simple as going for walks, breathing exercises, so making sure you take deep breaths, and that can help prevent lung complications. Stopping smoking, we know that even stopping smoking 1 month before surgery can improve outcomes in terms of recovery and maintaining good diet and nutrition. These are practical tips for, it would be more for elective surgery, and I'll quickly go through these. This was borrowed from the surgical unit that I work with. It's basically about being prepared for when you get home, just making sure that you'd arrange help for someone to help you with looking after pets, plants, arranging for cleaning, laundry help for at least 6 weeks after surgery, making sure you have non-perishable groceries, freezing meals for 3 weeks, and making sure you have someone to help you get to and from the hospital, fill your prescriptions, and maybe take you to doctor's appointments for at least at least up to 6 weeks after surgery. 5 to 7 days is the average hospital stay. This will vary depending on the procedure that you have had, and depending on age, if you have other medical problems, etc. You can see that the first day will be largely bed-bound with nothing to eat or drink, but as soon as the breathing tube is out, they would encourage you to sit up, start taking walks, and gradually you would be increasing your oral intake. And the key is keeping active immediately after surgery. So the main piece of post-surgical care will be about sternal precautions. You'll have stainless steel wires holding your sternum together. It will take about 8 to 12 weeks for the bone to heal, and the key piece is to avoid any complications. So the sternum breaking open, infections, and so you would avoid pushing, pulling, lifting, or carrying anything heavier than 10 pounds for at least 8 weeks, possibly up to 12 weeks. And you want to avoid any movements that cause pain or clicking of the sternum. Keeping the wound clean, so washing it gently and patting it dry, and keeping those deep breathing, coughing exercises to prevent lung complications. Pain management, usually that should be provided for you on discharge. And usually if you had persistent pain greater than 2 weeks, and that will depend on how many surgeries you previously had, your pain threshold, etc. But if pain is persistent after a few weeks, then that would mean you should touch base with your healthcare provider. And again, the key piece here is to stay active, and so mild to moderate exercise, really just walking is the key piece, to slowly keep walking as soon as you can when you get home after surgery as well. That is the end of my slides. I just wanted to make a quick little plug for the Heritable Aortic Disorders Symposium that we'll be hosting in Vancouver in May next year. It's a 2-day event, and the second day is for patients. So hopefully some of you can join us for that.
Thank you. Great.
Thank you, and hello everyone. My name is Siddharth Prakash. I'm going to be talking about cardiology management. So these are medications, lifestyle, and surveillance. I'm going to go quickly, so if you have questions, be sure to put them in the chat, and I'll try to get to them now or later. And this applies to individuals who've had an aortic dissection, are being followed for an aortic aneurysm, or have a genetic risk or family history that means they're being monitored for the development of aortic disease. So I'm drawing from the 2022 guidelines. These are the documents that tell doctors how to take care of patients with aortic disease. And these are based on the condition, some of the evidence that we know is helpful for preventing problems like having an aortic dissection. So as our previous speaker mentioned, blood pressure is the #1 risk factor for developing complications when you're at risk for aortic disease. This chart just shows that the lower your blood pressure is in follow-up after having an aortic operation, the less likely you are to come back needing a second operation. And this goes for all types of aortic disease, whether you've had a dissection or surgery. So it's extremely important, if you're in this category, to keep your blood pressure as low as possible. And that's where the number 120 comes from, 120 being the systolic or top blood pressure. We try to keep that as a goal for every one of our patients, and we use medications if you have high blood pressure. So these are the current recommendations for blood pressure management. And although it says 130/80, what I would say is 120/70 is reasonable. And we do recommend that people use specific medications with aortic disease, the main one being a beta blocker, which is like metoprolol, that slows the heart rate down, but it also helps protect the beginning part of the aorta. And if you have high blood pressure, we also recommend adding another medication called an angiotensin receptor blocker like losartan. It's a blood pressure medication that helps lower that blood pressure further. And these two kinds of medications, they work kind of complementary. One slows the heart rate down and therefore decreases the kind of force of contraction of the heart. And the other one kind of relaxes the blood vessels. So the two of them work really well together. And there's a lot of evidence showing from clinical trials that being on both of these at moderate doses is actually more protective than being on either one of them alone. So for most of our patients, we do try in follow-up to gradually build up their medication so that they're taking these two classes of medications at medium doses. Not everybody can get to that, of course, because there are side effects. And so one of the discussions we have is, should you start with a beta blocker or an ARB? Here, the beta blocker is atenolol and the ARB is losartan. And again, these were tested head-to-head in patients with Marfan syndrome, and there was no significant difference in the rate at which the aorta dilated or having aortic dissections in this group. So we consider them roughly equivalent for most of our patients. And the key in this trial is that most of the patients were taking at least 75 milligrams of one of these medications every day. So we do try to get that number up. And these are some of the discussions that you might have with your doctor. If you're starting out on a medication, there are certain factors that favor the losartan or angiotensin receptor blocker and certain factors that favor starting with a beta blocker. And so your doctor can go through those with you. Sometimes you may need a trial of a medication, and we can usually, after a few trials, find a medication that works well for you at a dose that you can tolerate. And we ask people to log their home blood pressures before and after the medications to see if they're getting close to that target number, and sometimes they need blood tests. So medical therapy points to remember, you need to know your blood pressure. There are many ways to do this, but taking your blood pressure at home is actually requires quite a bit of discipline. There's a standard way to do this, and it requires doing it the same way every time and recording them in a log. Sometimes you can have an app that records these for you, and your target systolic is ideally less than 120 on the top number. We use a combination of medications for people who need them. And the choice of these medications depends on a lot of factors that your doctor can go through with you after some testing. And you can combine the therapies as needed and increase the doses over time. The big drawback being getting blood pressure too low where you feel lightheaded or you feel dizzy. And in that case, you may need to modify the doses. And the medications here, the main point is they are for life. Even if you've had surgery, we know that especially if you have a heritable thoracic aortic disease gene mutation, you're at risk for recurrence of aortic problems or in other blood vessels, depending on your genetic cause, and you need to continue to be monitored and take medications. So these are some of the ideas that we'll return to, but mental health is also important when you're being followed because it can influence your blood pressure, and therefore we consider them to be cardiovascular risk factors along with all of the other physical risk factors that you've heard about. So anxiety and depression are important to monitor, and you should be able to talk to your clinicians about your mental health and get treatment if you need it, because without treatment, these conditions could raise your blood pressure and put you at risk for aortic problems. And so we believe that everyone should have a mental health assessment, particularly after you've had dissection or a surgery on your aorta, and offered treatment or referral if a mental health problem is found. Going towards exercise and activity is another major component of treatment for aortic disease. We consider an exercise prescription as important as a medication prescription for patients with aortic disease because exercise has many powerful benefits. It can lower your blood pressure, it can improve your cardiac health, and it can also increase your strength and resilience to overcome future problems. But before starting exercise, it's really important to consult with your doctor to make sure your aortic disease is stable and your blood pressure is well controlled at that target using the appropriate medications that we talked about. You want to start at low levels of activity and gradually build up. So start low and go slow. These are the particular recommendations on the left in the purple box that we give to patients and go through with them in clinic. I'm not going to go through all of these now, but there are ways to measure your intensity of your exercise even when you're on beta blockers, because your heart rate may not reflect the actual intensity of your work, since the beta blockers slow your heart rate. We want people to be very attentive to how they feel and not strain during exercise, because in our clinical studies, straining was associated with that higher surge in blood pressure that we talked about, which can be potentially worrisome for someone with an aortic problem. And of course, the best way to start out, if you're able to do so, is to have someone observe you exercising and giving you feedback, because that gives you the confidence that you're doing the exercises technically correct and doing things like breathing to prevent your blood pressure from getting too high. So if you're able to consult with a trainer or a physical therapist, we recommend doing so. We also have developed a checklist that includes all of these items, and this was developed with the John Ritter Foundation so that you can really understand what you need to know and when you need to do it. This includes things like what medications you should be taking, how frequently you should go to the doctor to get checked, what images you need to have, and why. So that if you can answer all these questions, you can consider yourself to be well prepared for your next visit for your aorta. And we also have a program called the Aorta Advocates. This is run through the John Ritter Foundation. They will run through this checklist with you and help you prepare for your appointments and also understand what professionals you need to consult with. This is the website where you can go to sign up, and you can be connected with an advocate who will work through this with you. They can also talk to you about things that we don't often think about, like life insurance, an emergency plan for what would happen if you did have, say, an acute aortic dissection, and other things that we've already mentioned. So we talked about surgery, but one of the things that is very important in aortic disease is sleep. We know that a lot of people with aortic conditions have sleep apnea and get poor sleep. So getting your sleep evaluated, preparing for surgery can be really important in terms of your resilience and recovery. And of course, a healthy diet and exercise as well. And then, of course, you want to talk to people who can advocate for you in all cases when you're not able to speak for yourself. So I'm going to talk about imaging now, because this is very confusing, since as you saw, the aorta is a complex organ that has many different parts. The most important thing to do is to make sure that every part of your aorta is being assessed in the best way possible. So the most frequent ways to do this are an echocardiogram, that's ultrasound of the heart, and that can view the beginning parts of the aorta very well. So if you think of the aorta as a candy cane, the echocardiogram can look at the very beginning short piece of the candy cane up to the arch at the top very well, but it doesn't do the rest of the candy cane much justice. So most of that is left out. And that includes the descending and abdominal aorta. You can also get a CT scan or MRI scan, and this is particularly important if you have certain conditions like Loeys-Dietz syndrome, which can affect other arteries that branch off of the aorta and may not be able to be seen on an ultrasound. And a special technique can be used to look at these blood vessels in great detail and really determine if there are any changes over time. So it's called an angiogram, a CT angiogram, or an MR angiogram. And that just means that it's a way to look at blood flow inside the aorta. And the surveillance that you particularly need is going to be different from somebody else, because it depends on which part of your aorta is affected. Is it the beginning part? Is it some part in the middle? Or is it a part down by your legs? That will determine what do you need only an ultrasound? Do you need a combination of an ultrasound and a CT or MRI scan? And how frequently you need it will be depending on how much that is changing over time. So what we know is that about half of people with LDS, for instance, have an aneurysm that's distant from the aortic root that would not have been detected by echocardiography. So it's important to know if you need some of these other methods. These are the current guidelines in that document about when and how you should be imaged. Generally speaking, everyone should get an echocardiogram at diagnosis. You should think about getting an MR angiogram or CT angiogram to see the rest of the aorta if you need to. And then your first follow-up imaging should generally be within a year. and then up as frequently as every 6 months or as rarely as every 2 to 3 years, depending on which parts are changing. And that can depend on the segment that's affected. So these are the major ways that aortas look like when you have an aneurysm. On the left is a normal aorta. It's not dilated. In the middle is an ascending aneurysm, and on the right is an aneurysm that affects the entire beginning part of the aorta. These are some of the most common kinds of aneurysms we see, and those can generally be seen well on echocardiography. If you have an aneurysm on the descending part, it may not be noticed. And this is what the aorta looks like on an echocardiogram. On the left, I'm showing a cartoon, and on the right, an actual patient with the same measurements. And these are the places where we measure the aorta to report it out. When you want to be looking at this, you want to line up the patient's images from 1 year to the next and look at them next to each other. That way you can tell if they're changing. That's why it's very important to get your images done at the same place so that they can line them up. If you get them done at different places, it can be harder to compare, particularly if you don't share images. This is what an aorta looks like in an MRI scan. And on the left, I'm showing the cartoon where we typically measure on an MRI scan. A CT scan looks very similar, and you can see the different points are very nicely laid out here and how you can see much more of the aorta on this scan than you can on the ultrasound. So how do we choose the imaging method? At diagnosis, we order a complete scan in general to look at the entire aorta. And the choice of the CT or MRI really depends on how frequently you need it. CT scans give you radiation and MRI scans do not. So if you have a healthy young person, we do not necessarily want to be doing CT scans every year for the rest of their life. That's a large radiation dose. We might lean toward MRIs, but in some cases, we need to do CT scans if there's an emergency that's much faster, as was noted. And then which aortic segments are diseased will determine how you follow up that. Do you need an echocardiogram because only the beginning part is dilated? Do you need a scan to look at the rest of the aorta? And it may usually what we do is some combination of an echocardiogram and a scan to look at the different parts of the heart and blood vessels. So each segment also progresses on its own schedule. So if you have aneurysms in more than one place, they can dilate at different rates, and you may need them checked at different times. That's one of the reasons we put on the checklist. You should know when your next images are due for each type of image.
Okay.
So points to remember about aortic measurements. Always know what's going on with your aorta. If you're not sure, it's okay to ask for a diagram. Know when your next set of images are due. Go to a place that's used to doing these images and can do them very easily and very well. And remember that the main difference between a CT scan and an MRI scan, besides the speed, is that the CT scan exposes you to radiation. So how do you find reputable images?
Sorry, I'm going to interrupt. We have 15 minutes left.
Sure.
And I want to get to the other two speakers.
Sure.
Reputable imaging centers, GADA has a list of aortic disease centers across Canada, which will be a little bit different than the US. So I'm just going to direct people to our website for that.
Yeah, and so I'm going to skip down to the end here because the real question is we want people to participate in research. And if you have a gene, if you know your gene, then please consider enrolling in MAC. MAC is a registry designed to understand what happens to people with specific gene changes. And if you don't know your gene, you can still participate in research through the John Ritter Research Program. This is our email address. They provide genetic testing usually for free as part of their research program for you and relatives in your family to identify new genes that we don't know about. So this is the way we've been able to move the field forward. Thank you very much.
Good evening, everyone. Thank you so much for giving me the opportunity to talk to you. My name is Julie. I'm a medical geneticist. So today I want to talk to you a little bit about what is genetic testing and why it matters. So we're talking about heritable connective tissue disorders and heritable aortic aneurysm. What does that mean? It means that you've either been found to have a change in a gene that we think leads to your aneurysm, that is in a gene associated with a high risk of aneurysm. And if that's the case in you, you could either have gotten it from one of your parents, but you could also be the first person in your family. It always starts somewhere. Somebody kind of invents it all by themselves in the family at some point in time. It could be that you have something that is another syndrome that could even be a problem or a difference with chromosomes like Turner syndrome that predisposes to aneurysms and dissection. Or it could be that you have at least one more family member who is known to have a thoracic aortic aneurysm, so in the chest, or dissection. And for that, most people who have aneurysms, until they have a dissection, if they have a dissection, they don't have any symptoms when they just have an aneurysm sitting in their chest. So the fact that your relatives are feeling well is not good enough. So typically what we say when somebody is diagnosed with an aneurysm is that what we call their first degree relatives, parent, siblings, often children, should have an echocardiogram as well to check their aorta, provided that where your aneurysm was is a region that was visible by an echocardiogram. Otherwise, just like Dr. Prakash said before, there's other imaging modalities to be used. And we're particularly suspicious in people who develop an aneurysm young, who have a family history of somebody who died young suddenly, or in people who have what we call red flags, features that make us think of things like Marfan syndrome, Lloyd-Dietz syndrome, or vascular EDS. And are all thoracic aortic aneurysm genetic? Absolutely not. About a quarter of the pie is. The other 3/4 are things where hypertension and age are probably the biggest contributor, but there's the other contributors that the first speaker reviewed as well. And why do we care about the gene? Well, we care about the gene because it will help us as a medical team take better care of you and take better care of your family members. So when we look at guidelines, there are guidelines of when, for example, to consider an aortic repair. And the key word here is consider, because it's not at that number necessarily that people will go and have an aortic repair. Deciding what somebody's surgical threshold is includes many things about you, and that's really a decision that's made with your medical team, with your cardiologist, with your surgeon. It is not just a number on the screen, but there's still quite a bit of variability depending on the gene and depending on whether the person has other things that we call high-risk features. And when we find a thoracic aortic aneurysm that is heritable, not all, but most of them are inherited in a way that we call dominant, which means that there's a 1 in 2 chance of passing down the predisposition every time we have a biological child. And I say passing down the predisposition because we know that these conditions associated with aneurysms can present quite differently even within individuals in the same family, and that the level of severity can be quite different even in the same family. And if you do go for genetic testing, what will happen is that you will either meet with a genetic counselor or with a geneticist. And in some places in Canada now, there's partnerships between genetic clinic and aortic clinic too, where the aortic clinic may get started on your genetic testing as well. And the chances that the test will pick it up, if you have Marfan syndrome, it's about 95%. If you have Lloyd-Dietz syndrome, about 95%. If you have vascular EDS, probably over 95%. But if you have what we call non-syndromic heritable thoracic aortic aneurysm and dissection, that means that if I was to see you on the street, there's no way that I would look at you and go like, oh, that person should really come to my clinic. You don't have those red flags necessarily. Well, then the chances that our technology will pick it up is only about 2 out of 10, which means that there's 8 families out of 10 where we know it's genetic and we know it runs in the family, and our genetic test still does not pick it up. So the fact that we don't find anything on your blood test does not exclude that it could still be a genetic aneurysm. And when we do genetic testing, we can find 3 types of results. We can find no answer. It doesn't mean it's not genetic. We can find what we call a likely pathogenic or pathogenic variant. We used to call them mutation. Variant sounds better. They changed the terminology. If we find these, this is something that we think is a genetic change that we think explains your aneurysms. And we can therefore use that to offer testing to your other family members to try to predict whether they might also be at risk for an aneurysm. Or we can find something that we call a variant of uncertain clinical significance, a change that we're not really sure whether it explains your aneurysm or not. If I go for a walk with 5 of my best friends on the street, people will be able to tell us apart. That's because we all have changes in our DNA. But sometimes the lab does not know if that's a change that brings you to the doctor or just makes you recognizable on the street. That's what they call a variant of uncertain clinical significance. If you had testing a while back, a few years ago, as we get better in science, as we get more information, sometimes some of those variants can change categories. So while your DNA, you're born with it and you'll have it for the rest of your life, the interpretation of the variant may not be something that is forever the same thing. The other thing is that when we look at the number of genes that have been discovered to explain thoracic aortic aneurysms, when we look at the 1990s and early 2000s, doctors would basically say it's Marfan or it's not Marfan syndrome, and that was the end of the discussion. And since then, there's been many more genes. Dr. Prakash showed you the paper from the American Heart Association. In that paper, there's at least 20 genes that should be tested routinely in people with aneurysms, even when their aortic valve is normal. And most commercial labs test more genes than that. So over time, the number of genes that we test changes as well. So it's not because you didn't get an answer years ago that you wouldn't get an answer now. But if no answer is found in your family, every time my heart beats, my aorta stretches and comes back. And just like if you were to play with an old box of elastic and there's one that's a little bit more friable, it's not necessarily the first time that you stretch it that it starts to not recoil nicely. So people who have a heritable aneurysm, their relatives need to continue to have echoes. Usually we see about every 5 years until they're 60 or 65 years old. So a normal echo in your relative who's 30 years old is not good enough. They need to keep checking their aortas. In terms of what does the gene change? Well, Dr. Prakash talked about a lot of things, but the other thing to know is that sometimes it's not just the gene, it's the specific type of change. So we know, for example, that in the gene for Marfan syndrome, in the gene for vascular EDS, in the genes for Loeys-Dietz, there are changes or types of changes that are more aggressive than others. So that's the kind of thing that your doctors want to know to be able to take care of you properly. And in terms of Marfan syndrome, a lot of people talk about the dislocation of the lens. And that's something that can happen at any time during your life. So that's something that you need to continue to follow up with your eye doctor for. And they also need to check you for other complications that people can get in their eyes. There's things in the skeletal system and in the teeth that they need to watch you for. And Dr. Prakash talked about sleep apnea and Marfan syndrome. There's studies that show that it's actually about 6 times more common than in the general population. People who have sleep apnea perceive pain more, so they're more tired, and they have an increased risk of aortic growth if moderate to severe sleep apnea is left untreated. So it's important for people to follow them. In vascular ADS, often there's a risk of dissection of all of what we call the large and medium artery and of hollow organs. So for example, we wouldn't want you to be constipated because we don't want that pressure in your gut. And the more you look like vascular ADS, the worse people do. And the type of variant, again, changes the risk with null variants, which are missing a strand in a 3D structure where there's three parts to the triple helix, is less bad than having a strand that disrupts the 3D structure completely. And female as a group, not on an individual basis, as a group, do better than males. And again, having your blood pressure not well controlled is not a good idea. You really do want your blood pressure well controlled. Again, the type of variant changes your risk. In Loeys-Dietz syndrome, Loeys-Dietz syndrome is kind of a cousin of Marfan syndrome, and Loeys-Dietz kind of sits in the middle. And again, we know that not all genes is created equal. The one at the top tend to be much more aggressive than the one at the bottom. So it's not just whether you have Loeys-Dietz, it's which gene you have, and also which change in these genes you have. Because if there are some changes that we know are worse than others, and it's possible that we just have no data on your specific change. If that's the case, well, this data was published in 2022, which means that before that, nobody had it. So this is something that people in the field are learning about continuously. So it's not because we don't know it now that we won't know it in 5 or 10 years. And when we talk about Loeys-Dietz syndrome, it's not just about the aorta. Your doctor will want to do imaging from brain to pelvis, but also monitor you for other things, a little bit like in Marfan syndrome for bones and joints, high risk of hernia. In terms of your eyes, typically we don't see the dislocation of the lens, but we can still see myopia, so not seeing well far away, and retinal detachment. People with Loeys-Dietz tend to have more allergy and immune problems, and some people can have what we call a cleft palate, or hole in the palate, or bifid uvula, or skull bones that kind of fused a little bit too early. The skull bones that fused a little bit too early is not there in the majority of people, and neither is the cleft palate. And then there are other genes that, given the fact that we're running quite late today, we will not talk about. But one of the things that's really important to remember is that people with these types of disorders often have joints that have a mind of their own, and that often comes with fatigue, with pain, with anxiety, and being able to have an exercise program respecting the recommendation of your cardiologist is often really helpful in helping with all of those, and getting your sleep treated if you have sleep apnea and you need help. That will also help with these symptoms, so it's important to not overlook them. But now Gretchen will talk to you about mental health.
Well, I was going to offer, do you want me to come back and give my talk at a different time so you can get to the questions? I'm totally happy to reschedule so that people aren't stressed out and super overburdened. So if you want to take that option now, I'm totally giving that to you.
I will take the option. Maybe do you want to just summarize your talk in maybe 5 minutes, and then we'll get to the questions? Is that fair? And then we can invite you back for the full thing.
Yeah. You know what? So the summary of this talk is that I was at the Marfan conference this summer, and we were talking to people in our session who had aortic dissections. And I usually always say this statement of like, after a dissection or an event or a surgery or a diagnosis, you have to learn to trust your body again. And the individuals in the group really, really questioned me and said, no, that's not right. That's not right, Gretchen. It's that we have to begin to live with an untrustworthy body. And so I just wanted to explore that a little bit and kind of all the feelings that brings up in terms of anxiety, depression, trauma triggers, etc. And also like how to reframe how we think about that. That, you know, your body isn't broken, that you can't trust it. But, you know, just like we need to kind of repair our bridges sometimes, we need to kind of refocus and restructure and just really maintain your bodies and your mental health, and how that is really, really intrinsically kind of intertwined. And then some tools on like, what does it look like to reset your autonomic nervous system? And what does it look like to find those things in your life that bring you peace, as well as some resources. So I will definitely come back and lean into this bridge metaphor of mental health and physical health at a future time, but I'm totally cool with that, Andrea.
Thank you for your understanding, Gretchen. So just for all of our panelists, we have 3 questions that I wanted to get to. So the first question is, what is the maximum weight I can lift or carry with a chronic type B dissection with aneurysms at the subclavian and the infrarenal?
I can start with that one. So our team conducted a clinical trial with patients who survived type A or B dissections, and we asked them to lift weights as well as perform aerobic activities. We measured their blood pressures while they did all of these activities, and we came up with a series of guidelines to avoid certain movements and stay within a safe range of physical intensity. The answer for the weights is that you can lift whatever you can lift without straining your chest or abdomen, or to the point of exhaustion. We found that if people were lifting and visibly straining, we could measure sharp differences in their blood pressure during the chronic phase, the tonic phase of the lift, and that if they became exhausted and they couldn't do it anymore, then they also developed very high blood pressure. So as a general rule of thumb, you want to maintain a moderate intensity, and there are ways to do this with what's called a rating of perceived exertion scale, and also avoid exercising to the point of exhaustion. And we developed several of these parameters that we're creating a brochure to highlight for patients.
Okay, thank you. Our next question. I was just diagnosed with Loeys-Dietz syndrome type 3 at 58. My blood pressure is 120/70. My heart rate is 66. My scans were great. I take 10,000 steps a day. Should I be on medication?
Yeah, well, as I said in my talk, medication is for life. We take that seriously because we know that individuals are at risk, a constant risk throughout the life. If we look at what's called the event curve or the Kaplan-Meier curve for people with LDS, it increases continuously throughout life. So there's no point at which we can say an individual is without risk of having a future aortic event, even if it has been decades while they've been under surveillance, and even if they haven't had a previous event. So for that reason, we recommend lifelong medications.
Okay. All right. Next, my children have a cousin with a bicuspid aortic valve. We don't have any info on whether or not this is genetic. Should my children have yearly echocardiograms? Anyone?
I was going to let Julie take that.
I was gonna say,
Okay.
I'll give an opinion, but I'm sure everyone might have opinions.
Yeah, I can take that now. So the cousin with the bicuspid aortic valve. So yeah, no, so first degree family members should be screened with an echocardiogram for a bicuspid aortic valve, but if they do not have it, they do not require ongoing screening.
Okay. All right. Next, what supplements or foods are good for lowering aortic dilatation?
So there is not a lot of research on supplements or foods. What we do know is that certain foods or types of minerals in food can affect your blood pressure. And as we said, blood pressure is super important for people with aortic disease. So we recommend following a diet that is intended for people with high blood pressure. And that means limiting things like salt in your food and certain types of fats. So if you have a balanced diet that's low in salt, the kind of diet that people would use to control their blood pressure is generally what we recommend for people with aortic conditions. And you may hear about a lot of supplements that people take, but there aren't any clinical studies to really verify that they prevent or treat aortic dilation.
Any recommendations for long-term lifestyle? Anyone?
Everything in moderation and enjoy life, but be healthy and make wise choices. Avoid crack cocaine and avoid those heavy weightliftings, like Siddharth said. Yeah, I think it really is like that balance of not living in fear, but like being healthy with your diet, your exercise, getting your scans. So, we do know that like in some of these syndromic conditions, right, with a musculoskeletal disease can cause a lot of pain as you get worse. So really trying to get that good exercise swimming regimen in at a young age is going to help your body through the aging process, I would say.
Okay. All right. Somebody had asked, what are the critical measurements for a Loeys Dietz patient to get surgery? And Julie showed a great table of that. So it depends on the gene and other features. So I think we've answered that one. What are the current guidelines about when to have surgery and best practices for limiting aortic growth? So this is a question from someone with Marfan syndrome.
Go ahead, Julie.
Oh, go ahead, Nat.
Oh, no, go ahead.
So for Marfan syndrome, for an adult with Marfan syndrome, the standard surgical threshold is 50 millimeter. The highest surgical threshold is to consider it at 45 millimeters. So that means that again, with your surgeon, depending on your family history, depending on your other risk factors, depending on the rate of aortic growth, depending on the number of patients of parameters, they will decide on the surgical threshold with you. Like that's a joint decision between the members of your team and you. And in terms of the best thing to do to avoid aortic growth is to control your blood pressure, like Siddharth said. So those medications that he talked about, either beta blockers, so those are the LOL, labetalol, metoprolol, or the angiotensin receptor blockers, those are the sartan. Those sartan, ibesartan, candesartan type of thing are the classes of medications that are commonly used. And like he said, like everybody said, actually a healthy lifestyle and avoiding exercises where you strain. And the reason for that is that every time you strain, your aorta hits your blood hits the wall of your aorta, like kind of really hard. And on the fragile aorta, the aorta doesn't like that too much. So that's how you can protect your aorta in the long run. I don't know if you have anything to add, Gnalini?
No, I think that was it.
All right, this question I can answer. Does my hospital share its information with GADA? No, they do not. Is there any change to guidelines for someone who's 20 years post-dissection with a mechanical valve? This person has BAV-related aortopathy.
I can take this one. Is there any change to the guidelines after a mechanical valve? Was that the question?
Yeah.
Yeah, I don't think there's been any changes in guidelines with regards to mechanical valves. Did they have a replacement as well, or is it just the mechanical valve?
It just says, I don't have that. It sounds like they have a mechanical valve replacement 20 years ago, and they want to know if there's anything changed. It's a St. Jude one.
Yeah, there's been no changes to the guidelines really in terms of mechanical aortic valves for a while.
Okay, good. Someone didn't tell me what type of aortic disease they have, but they said, I take a beta blocker and my heart rate ranges from 50 to 60 at rest. Is that good enough?
So the goal of treatment with the beta blocker is not necessarily based on heart rate or even blood pressure. It is really to reduce the wear and tear on the aorta with each heartbeat, like Dr. Richer said. And so it slows the rate and force of heart contraction. Even if you have a normal blood pressure and resting heart rate, we urge people to take a beta blocker. As you said, there isn't really a number that we look at. Many people, for example, young, healthy, athletic people can have a resting heart rate in their 40s and they will be fine. But for other people, they might get lightheaded or dizzy at that number. So it really depends on the symptoms, how low your blood pressure is, and whether you're tolerating the dose. And as we said, the higher the dose of the medication, the more protective we believe it is. So we do try to increase it as much as you can tolerate.
Okay. All right. Is an open repair the best way to fix a type B dissection for someone with Marfan syndrome? I don't know if, I know you guys aren't surgeons. I don't know if anyone feels like fielding that one.
I'm not a surgeon, but I think it's a bit controversial. And I think it depends on probably a little bit on the center and their expertise. There are definitely benefits with an endovascular approach, minimally invasive, shorter recovery time versus a repeat, it's not a sternotomy, it would be a thoracotomy, but I think the data would suggest that maybe there are a bit more late complications in Marfan's patients with endovascular procedures, but I think it does depend on the center and their level of comfort doing those procedures in patients with connective tissue disorders, because I know in our center we do TVAS in some of our Marfan's patients. So I think it depends a lot on the center.
Okay. Next question is, how can you find out if you have a gene for aortic dissection? So if you're within Canada, the best way to do that is to speak to your family doctor or walk-in clinic about a referral to medical genetics. As Dr. Richer mentioned, some places in Canada have genetic testing available in cardiology, and we have a list of places to access testing on the GADA website. What is the best test for me knowing my brother had an aortic dissection? I am in my 60s.
So there's a few parts to your answer. So your brother who had an aortic dissection, if you're considering genetic testing, we always want to test somebody who we know has the condition, because as we discussed, only 20% of the time do we find the answer. So if we do a genetic test on you without knowing if you have an aortic problem, and we find nothing, then we don't know if we would have found it in your brother and you don't have it, or if we wouldn't have found it in your brother and we have no idea whether you have it. But what you do need, if your brother had an aortic dissection, is for you to have your aorta imaged. And how your aorta will be imaged will depend which part of the aorta dissected in your brother. Because when we do an echo in most adults, it's like putting a box around the heart where we see the root, the part close to the heart, and part of the ascending, the part that goes up, but the other parts of the aorta often in an adult are not well seen on an echo. So the best test for you will depend which segment of the aorta on your brother.
Okay. Our next question, again, I know you guys aren't surgeons. Any thought on using a TEVAR to replace a regurgitating valve in an otherwise healthy Marfan patient? Does anyone want to take a stab at that, or are we going to defer to surgery?
I can take a stab at that. So TEVAR is for the descending aorta. I don't know if that was so. And when you're talking about the aortic valve, I don't know if they're referring to a TAVR as opposed to a TEVAR. So maybe it's a TAVR. Everyone's nodding their head, so I think that's what I'm getting. So, a transcatheter aortic valve replacement. So I think there's a few different aspects to that. I think one, again, it's minimally invasive, quicker recovery. But I think the thing to consider is the durability of these valves. So, you know, in terms of long-term data, we probably have like 15-year data. And so if it is a younger patient doing a TAVR valve, will that last their entire lifetime? Will they need future surgery after that, etc.? So all the trials with TAVR are really in older patients. And so I think it would be a little bit controversial to do it in a very young patient. But if you were older, I think it's definitely a pretty good option here at our center. We've definitely done some minimally invasive procedures for some of our aortopathy patients just because, there's quicker recovery, obviously not having another stenotomy, etc. So it depends on the age of the patient, but it's a consideration.
Okay. What are the screening guidelines for the children of someone who had an aortic dissection with no genetic cause identified?
That's a great question. And that's a question that different people will answer slightly differently. So the way the European guidelines are written is that they say to start to screen at 25 or 10 years before the youngest person in the family. The problem with that is that somebody who presented with an aortic dissection, we don't really know at what age they started dilating. And chances are that person started dilating younger than they had their dissection. So depending on which age you had your dissection, I know that, for example, our pediatric cardiologist, when somebody is diagnosed young enough that their children are still young, they still want to follow them. So that will depend on the center and at what age you had your event.
Okay. Thoughts on a pairs procedure for those with lung issues. If you have a low BP and we have the blood pressure is 95/65, can you take an ARB to slow aortic growth? That's from someone who has Marfan syndrome.
I'll take the ARB question, part of the question.
Okay.
The answer is sometimes yes. It really depends upon the individual response to the medication. And as I mentioned, it's frequently necessary to give a trial of low dose, and individuals are surprisingly able to tolerate it even if they have normal or low blood pressure. Now, many times that is not the case, and so we can find alternative medications like beta blockers that might work for those individuals. And it does take some trial and error in certain cases. But usually we can find a combination that works for most people.
Okay. This might be a good question for you as well. For a child that has Marfan syndrome, how do we know if they're getting enough exercise? That's a loaded question.
It's a great question. And really, it really depends on the child. So children with Marfan syndrome, there's different types of presentation. There are children who are the first in their family to be diagnosed with Marfan syndrome. They're typically more severely affected if they're diagnosed as a child. And then there's children who have a parent with Marfan syndrome. We knew exactly which change to go look at, and we knew to go look for Marfan syndrome in this family, and that's way more variable in terms of presentations. So some people with Marfan syndrome have what we call a myopathy, which means that the muscle itself is not as strong. And that can limit the ability to exercise, and so can the joint hypermobility, those loosey-goosey bendy joints. So an exercise program in a child with Marfan syndrome is really something that needs to be individualized. And but in general, we still want them to be kids and be able to play as long as it is safe. So that's a conversation with your healthcare and team and with your cardiologist. I don't know if anybody has anything to add. Gnalini, I think you're a pediatric cardiologist, so maybe you have more.
I'm an adult cardiologist, but all I can
sorry.
That's okay. All I can say is I think the key piece is to stay active. I think that's a huge piece, and I think there's a it's a myth for so long that patients, and some of the older patients will come and they've been told in pediatric life that they shouldn't exercise, etc. And I think one of the biggest disadvantages you can do for yourself is to be sedentary and to gain weight, and that can also have such a negative impact. And so I think there's a study that looked at pediatric patients. I think it was with Marfan, and they found that more steps was associated with better outcomes in terms of aortic dilatation and events. And so I think being active is key. It does, and I think just avoiding those high intensity exercises where you're going to get like bursts of high blood pressure, that's what you're trying to avoid. But making sure you're actually active, and it can be as simple as going for walks. Walking is underestimated.
Okay. 2 questions for Julie. If the parents don't have Marfan syndrome, how does it develop in the child?
That's a great question. And it's basically because it always starts somewhere, whether it's with your generation, your children's generations, your parents' generation. When we make a human, if you will, our body has to copy literally millions of letters to make a human. And it's, in my books, a real miracle that we mostly have 2 legs and 2 arms, because the amount of mistakes that get corrected while making a human, and every time our cells divide, is actually quite amazing. So sometimes there's a spelling mistake that arises, and that our cellular mechanism don't catch to come and erase it and put the right letter there. But if you were to look at all of my genes compared to my parents' genes, there's probably about 400 things I invented all by myself. And most people are lucky enough that those 400 things are in places that they'll never know because they don't matter as much. But sometimes one of those things happens somewhere where it really matters. And that is because we as humans are quite imperfect, all of us.
Thank you. Two more questions. How many years would typically be between aortic valve replacements?
I think it would depend on what was used for the valve replacement. So a mechanical valve should technically last the person their lifetime, versus a tissue valve, on average, it's probably going to last you about 10, maybe 15 years at most.
Okay, thank you. And what should we look for in terms of signs of an aortic dissection? Are they typically precipitated by something like a sudden shock, physical exertion, caffeine, emotional distress? Is it possible to have no prior symptoms and only to experience a sudden catastrophic event?
I would say that most of the patients I see, it's often not precipitated by anything, and it can be often come out of the blue. But there are certainly, I can just remember certain events where people have been working out at the gym or etc., like those instances where there is spikes in blood pressure, but often it can be when you're doing your day-to-day activities. And I don't think we really understand why that's the case. And I kind of wonder if it's because, there's been obviously gradual strain put on the aorta leading up to that point. But certainly I would say the majority of patients have some symptom, and usually it is the classic one that I described, that chest pain or sharp abdominal pain, but there are lots of others that present a little bit more vague in terms of their presentation. And I think that's why, if you think it feels different to what you usually feel, then I think it's really important you speak up and advocate for yourself.
All right. Well, we are about 30 minutes over time, so I wanted to thank all of you for coming. Gretchen, we will be in contact about coming to have you back. Thank you so much for your understanding, and thank you for taking the time out of your day to speak to us, and to all of our attendees who came to the webinar. We really appreciate it.
Thanks, everyone.
Thank you.
Thank you very much.
Have a good evening.